From Ausmed Education, hello and welcome to episode 6 of the Care to Learn podcast series. I'm Wayne Woff, and each month we sit down with interesting and influential professionals working within healthcare and education. In this episode, we'll be talking to Tracy Edwards, a nurse practitioner in a busy emergency department. Tracy is passionate about clinical practice and has a huge hunger for new knowledge, always taking the time to investigate what she doesn't know. In today's episode, we'll discuss how, as a nurse practitioner, Tracy is able to pass on knowledge to her colleagues and help others to really embrace education. We'll also touch on successful approaches to learning in a busy emergency department, potential issues that have come from regulating CPD, and the strong link between leadership, teamwork, and a department's attitudes towards learning. So let's get into it. Welcome, Tracy, to our Care to Learn podcasts here today at Ausmed Education. We'll kick off our discussion today by getting you to discuss with the audience or tell us a little bit about your professional journey and how you came to be a nurse practitioner in the emergency department.
Thanks for asking me to do this. I started nursing 1983, so 30 odd years ago, and I always wanted to be a registered nurse. And I didn't do very well with the HSC, so I went to Sydney and had some interviews and was basically told that I wasn't smart enough to be a registered nurse, that I'd be better off as a nurse's aide. So I thought, okay, well, I went and started my nurse's aide course, finished that. And then I went back home to Canberra, worked there for 12 months, and then my family moved to South Australia, to Woomera, out in the boondocks. So stuck in the middle of the desert, I was lucky enough to get a job as an enrolled nurse, and I used to be in charge of the hospital transfers in the ambulance. And then I worked in Port Augusta for 12 months until I got into my hospital training to become a registered nurse in 1986. And I did my 3-year course through the Queen Elizabeth Hospital in Woodville, and then I went into private. I decided that I wanted something different, so I went to the cardiac unit at one of our private hospitals, Ashford, where I started, worked there for 18 months and then found myself as a unit manager 3 years out of my training, which was probably a good thing for me because then I got to see both sides. I became the unit manager, and then I got married and had children, so I moved up to the hospital that I'm at now, and I've been there since 95. Worked in coronary care, and then in 2005 I had an epiphany and thought maybe I'd like to be a nurse practitioner. I'd been studying all the way through. My husband said my hobby is studying. It's not really, but to get where I am, it took many years of different courses, and so in 2008, I became a nurse practitioner candidate. And in 2010, when I finished my master's degree, I was lucky enough that I had a very progressive nurse, director of nursing at the hospital I work at. And she said, you will be our first nurse practitioner in ED. So I was handed the position, and I was very lucky.
Fantastic. I should have shared my story with you briefly before we started here today. We've got almost a common career path. I started as an enrolled nursing student in 1982 and went on to do my general training. You said yours in 1986. Mine was just a couple of years before that in 1984. But just picking up on your point about having that epiphany and wanting to become a nurse practitioner, what was it about potentially being a nurse practitioner that attracted to you when you had that light bulb moment, if you like?
I like working in a team, in the ED team. I was clinical nurse when I made this decision, and I'd been a unit manager, I had been quality and clinical risk manager, I'd done a few other things, and I just decided that I wanted to stay clinical. And I thought there's probably no reason that I couldn't become a nurse practitioner, because I wanted to be able to see my patients from when they presented to when they went home. And I wanted to be able to do the lot. ED is a very fast-paced environment. In one shift, you can go through 10 patients. You see them, they get better and they leave, and it all happens very quickly, whereas it's a bit of a slower pace as a nurse practitioner because you are doing everything, and I like that.
And I think it's been a terrific evolution of the profession that opportunity is given to people who want to stay as clinicians and not potentially become nurse unit managers, D-dons, dons, etc. Because there are a large group of the nursing profession that are passionate about their clinical practice and want to stay in it. You'd agree with that?
I agree, yeah. I mean, I don't necessarily get students working with me in this role, but I work from the triage area because I see what presents and I think I'll have that patient because that's something that I can see and treat.
Yep.
And if I have a student there, I'll always take them along and say, well, you come with me and you can learn some assessment skills, and if I need any injections done, you can do the injections. If I need blood taken, then I'll show you how to do it. So it gives me that chance to hand on some skills to a student nurse and to show them that, you could also do this.
Fantastic. We'll dive into our first question that has more an education focus and just ask you, do you view education differently now that you're a nurse practitioner, potentially from the point of view of educating yourself and also educating others? So do you view that education space differently now that you're a nurse practitioner?
Not really. It's probably taken me 15 years of study to get where I am. By the time I did my grad dip and then I did my ED course and I'd already done my coronary care course, and then to be a nurse practitioner you have to do your masters, and I'd also gone along the way and got management qualifications as well through uni. So my husband's idea that I was studying as my hobby, 15 years of studying, yes, it probably was my hobby back then, but now if there's something I don't know, I will always go and look it up. So I still have that, if I don't know it, then how can I treat it attitude. So I'll always go and look something up, read, and I always say to my kids, if you don't know something, you go and look it up in your Funk and Wagnall. And they go, Mum. So I've always had that, if I don't know something, I'll look it up. And I've always one-on-one, even when I was a registered nurse, would take people aside and say, look, how about we do it this way? Policy states this. You can still do it this way within the policy framework, but it will be easier for you. So I still do that with people and try and educate along the way as well. Even though we have a dedicated clinical educator in the ED, I feel it's every nurse's role to educate people. So no, my attitude to education hasn't changed.
And that imparting of a hunger for knowledge is obviously a key component as to how you would interact with others and get them to embrace education.
Yep.
That hunger for knowledge is very important from what you've said.
And you find it in some people. Some people will come and ask you every question under the sun and you think, oh, they've just asked me something that I don't know. Okay, well, no, I don't know that, but let's go and look it up.
Yep.
And then you'll have people that just don't want to know. And they're the challenging ones. They're the ones that you have to say, look, you really need to know this. Let's go and have a look. Or, look, I've just read this article. Here, you have it now because I've read it. It might show you a better way of doing what you're doing.
Yep. Okay, taking that conversation just a little bit further, given the nature of work you do in the emergency department, are there particular, and you probably touched on a couple already, but are there particular approaches that you take to that role of staff education in that specific environment of the ED? Are there particular approaches that you like to take or you think are most effective?
I usually like the one-on-one because I think you can be more personable, and I find it easier to explain things to students or enrolled nurses or registered nurses one-on-one. In the ED, it is very hard to get to education. You find the nurses, even though we have a double staff time education session, if it's extremely busy, they don't get to go. So trying to get staff off to education is always difficult, and sometimes you have to do it in small groups of 2 or 3. And that's what our clinical educator does. The other format that we use in our ED is by the way of learning packages. So to be able to work in the resus room and be the airway nurse, you have to have done the package to get to there. Then you have to have orientation, then you have someone standing with you, so that's more one-on-one type education. I see that work in some aspects, and in some other aspects it doesn't work. Same to work at triage, you have to do a package. Some nurses will take it further than the package and will do more reading. Some will just do the package. And you can always tell the nurse that's done the extra reading, because they're the ones that think outside the box and might ask the odd question, and someone behind them will go, well, why'd you ask that? And they'd say, well, because of this. So you can always tell someone that really wants to learn. And I think sometimes doing a learning package helps, sometimes it doesn't.
Well,
it's a means to an end.
Yes, as you've just described, for some people, the package can tend to define the learning and hold it back, rather than other people who will perceive it as a launching pad, as a starting point for further learning and taking those opportunities.
Yeah.
So it really probably segues to my next question in terms of what you think are the most significant impediments to staff embracing ongoing learning. In your experience across a career that spans more than 30 years, your observations and from your current clinical setting, the most significant impediments to ongoing learning?
I think people think they have to do all their learning at work, some of them. And it's not about that at all. You have to do some of the learning at home in your own time. You can't learn everything at work. And I think with these new APRA standards that have come in, where you have to have 20 points of education, continuing education as an RN, and nurse practitioners have to have an extra 10. I think in some ways that's good because it makes people learn. And in some ways, I think it can be a bad thing, because I think I've got my 20 points, I've ticked that box, I'm done. Whereas I look at it as that's a standard, a minimum standard that you have to have. So, when I have my annual PR&D, they always say, well, what have you done? And I use the Ausmed app for documenting my PR&D, because it's a great thing. I can print it off and go, well, there's my 100 hours of earning. I didn't do as much as I did last year because I was sick this time or whatever. But some people will hand in their 20 points and you go, now what have you learned? And I think that can be an impediment.
And I think you're quite right that regulatory environment, which will always tend to set a minimum, can be both a positive and a negative in the space. And I think that love of learning is something that is very personal, but is also a collegial thing and a workplace thing where it can be absolutely engendered. Let's move now next to what you would see as some emerging trends in education in the emergency department. I suppose activities or modes or methods that might be being used now but weren't being used maybe 5 years ago, 10 years ago, 15 years ago. Have you seen some emerging trends in terms of education?
Not a lot in our department, I hate to say, but we do use preceptorship a lot more.
Okay.
My day, never would have seen it. They threw you out onto the floor and said, you're the RN on duty, and it's like, oh, dear God. But now we use preceptors. So the students will get a preceptor and they know that that's that person that's going to teach them and help them through their placement. But we also now use preceptors a lot more for our enrolled nurses, our RNs, so that they have a go-to person. So if they have a procedure, say they're in the resus room and the doctor says, we're going to put an underwater sill drain in, and they've gone, oh, no, we're not, because I don't know how to do that. They can, if their preceptor's on, they can go and find the preceptor and say, I have to do this, I need help. And that preceptor will come with them, bring the procedure, show them how to set it up, make sure that the next time they're in that situation, they can go, yep, no worries, I know how to do this. And I think that has changed. That's one thing that when I went through, I didn't have a lot of. And I think we need more registered nurses that are willing to take on that role so that we can educate other registered nurses so that they can educate the next registered nurses. Because I think if we don't, that old saying that nurses eat their young, it's not a good thing. We need to push people and we need to say, look, you are a good teacher. You need to put your name up to be a preceptor of someone.
And do you think people are warming to those roles? Are you seeing more people
in
that are willing to put their hands up?
And they're not just clinical nurses. We've got registered nurses that are preceptors, and sometimes they are the best preceptors because they've been there, and they're not necessarily nurses that have been there 10 years. They can have been there 2 or 3 years. We have some great registered nurses in our department that have only been there 3 or 4 years, and they make the best preceptors.
And do you think that extension of roles by taking on the title of being a preceptor tends to enhance teamwork, that sense of shared responsibility, that sense of we're all in this together?
Yeah, I think it very much depends on the RN as well. Certainly in our department, we are only a very small department, but we were always busy, and there's always that teamwork. And there's always, yes, we've got more patients than we've got cubicles for. What can we do? How can I help you? I've done my OBS or whatever for my 3 patients. What do you need doing?
Yeah.
And that comes from leadership. That doesn't come from, the RN alone. That comes from the top. So the nurse unit manager, the clinical nurses, everybody getting in together and showing that we'll work together and we'll get through this. So I think that makes a big difference.
And you just touched on it. I might take that a little bit further before I ask you my next question, and that's the link between leadership and education. For you, that link is incredibly strong by the sound of it?
In our department it is,
Yep.
yeah. We have I don't know what you call them in Victoria, but we have clinical nurses and associate nurse unit managers, which is the next step up, and then the unit manager. So all of those nurses are well aware of the staffings and what's going on and who might need a little bit of extra help or education. The clinical educator will get involved. The nurse unit manager and the clinical educator come out on the floor during the busy times so that the staff can see that leadership. Hey, look, we're all in this together. I'll muck in and help you. Or what do you need help with? And I think that makes a big difference.
Terrific. I'll now pick you up on something that you identified before, that you'd previously been in quality and clinical risk roles, quality and clinical risk manager. Given your experience in those areas, could you speak to us a little bit today about what you see as the link between quality, risk management and education, and what observations you'd make in that space?
As a risk manager, a lot of the stuff that comes across your desk are either incidences that have happened or near misses. And reading some of those incidents, I must admit, some of them godsmacked me and some of them I've thought, I'm not surprised that has happened. So I think to provide quality care, you need to make sure that your policies and procedures reflect the care that is required, and that every nurse knows that if you don't follow that procedure and something goes wrong, it's not going to hurt you, it's going to hurt the client or the patient. And I think educating nurses on those procedures and having an understanding of what is exactly wrong with your patient, what they require, and what might be required. So forward thinking, okay, I've septic arthritis, for instance. I've got a patient with septic arthritis. Well, I know they're going to need pain relief, regular OBS, that they're probably not going to be able to move around the bed, so they're going to need a risk management plan, pressure care, all of that forward thinking, because if something happens to that patient, it's going to end up on the quality and clinical risk manager's desk.
Yeah.
So there is a link between all of those three, and it's important that as registered nurses that we understand that everything that we do has an effect on the patient, and it can be a negative effect.
Yeah. And I think you bring up a hugely important point that I've seen throughout my previous clinical career, and that's registered nurses and other staff's intimate knowledge of policies or procedures and lack thereof.
Yeah.
In terms of, at times we can write tomes, we can write Bibles to policy and procedure, yet they will sit on the shelf.
Yep.
That they're not used as an adjunct and an integral part of an education program. Do you think that's true from what you've said?
We have quite a good system. We have what we call the Triple P portal system that has all our policies and procedures on it. So every nurse can get onto it.
Yeah.
Whether or not they get onto it and use it is up to them. So I try and always, and in my role as a nurse practitioner, the buck stops with me. So if I do something wrong, the only person to blame for that is me. So if I have provided the wrong treatment, then I have not either thought about what's the right treatment, or I might have given the wrong antibiotic, or I didn't take a good enough history. Trying to show registered and enrolled nurses that you are responsible for that care. If something goes wrong, you can't just say, well, I didn't know. the buck stops with you as well. Buck stops with everybody. We are all responsible for the patient. So it's important that you know what policies and procedures, how to do things. When you're about to step over the line, think, well, if I do that, what's going to happen? Not, it's all right, I'm covered. You have to have that risk mentality that whatever you do, and I after doing the quality and clinical risk job, when I pick a patient up, and it might be a knee pain, I'm always thinking, okay, it's a knee pain, but what can go wrong? So I have a formal way of doing things so that I tick all the boxes. And then before I discharge my patient, I always go back and think, okay, now have I covered my bases? Is it that? What else could it be? What are my other diagnoses? When do I want them to see the GP? So that I'm covering all have the patient got the correct care for the right thing? And is there a risk that the patient could deteriorate?
And I would imagine that's a significant focus in the ED, that sort of clinical risk mitigation in terms of the management of clients, liaising with doctors, when to escalate care, etc.
Yep. We actually brought in our own little MET system in the ED so that if a nurse had a patient that suddenly dropped their blood pressure and it didn't meet within the correct variables, that the nurse could call what we call an ED MET call, and that would get you the nursing team leader and the ED consultant, so that you knew that if anything, if your patient was deteriorating, you got immediate. If you couldn't find the doctor that was looking after them, you'd just call the ED MET call, and you'd get a doctor and the nursing team leader, and then the patient's care could be escalated. So we found that having that system in place mitigated a lot of risk as well.
Yeah, terrific. Well, you've provided the audience and myself some great insights into the areas that we've discussed today. We'll just finish off with some of our traditional closing questions, the first of which is, what's one thing you've learnt in the past month that has really stuck with you?
Never take a presentation on face value, for me. I sit at triage and the nurse will be triaging the patient and the patient's booked in with shoulder pain. And you think, okay, shoulder pain. Is it shoulder pain? Is it something else? So never take anything on face value. I've had a patient with shoulder pain that turned it out there was nothing wrong with his shoulder. He actually had chest pain, which is way out of my scope. But when I drilled down to it, it was like, okay, well, we're moving into a cubicle and you're getting handed over. So it's never just a knee, a shoulder, I need some stitches. There's always a story behind it.
Yeah, never be blind to the other possibilities.
No, yeah.
The second of our closing questions, what's your favourite personal learning tip?
Probably read. Read and investigate. If you find something that you've never seen before, or the doctor says the patient's got this and you don't know what it is, go home and find out what it is. You have to do some education in your own time. Your 20 points is not going to all occur at work.
Yep. So that sense of personal responsibility to take it a bit
I think
further.
We all have a responsibility to learn and make sure that our patients get the best care, and they're only going to get that if you make sure you know what you're doing.
And our final question for our podcast today, what's the best advice you've ever received about continuous learning?
Probably from a registrar who now works at Harvard, and he taught me how to do a proper full-on medical assessment. And he said to me, don't just stop with what I've taught you. You always have to go on and add to that assessment. So here's a basic skeleton and you fill in the blanks.
Yeah.
And he was great.
Fantastic. Well, we thank you for your time today, Tracy. It's been terrific to have you with us, and many thanks.
No worries. Thank you.